Oh, hello, everybody. I hope everyone's having a good day. Today's lecture is going to be venous angioplasty and stents. My name is Rob Cruz. I'm from Loma Linda University, and I teach in several programs, including the prep course program that gets people ready for the ARRT vascular interventional, or the VI exam. I also teach in the cardiac section, electrophysiology, and some others. Anyway, so today's lecture is going to be on the vascular system and specifically venous angioplasty and stents. Today's roadmap is going to cover normal anatomy. So we're going to take a look at the layers of the normal vessels. Also take a look at the elastin fibers and why they are important in angioplasty. We'll take a look at a couple of words and to define them so we know what we're talking about on the same page. We're going to take a look at specific disease processes. We're going to look at intrinsic and extravascular impingement. So intrinsic, extrinsic forces that require us to go in and balloon and stent a vessel. We'll also take a look at Bud Chiari with a little more detail than the other ones. Vascular pathology, and the procedure itself, and the thoracic outlet. So that is today's agenda. For here, we have several nice things to look at. So nerve fiber bundles are over here. This is your skeletal muscles. LV is the lymphatic vessels in the cellular matrix here. There's a couple of them dispersed in between some of the other cells. Here we have the artery. So the artery, of course, has the lumen in the middle. Then it has the intima, the media, and the adventitia. So those are the three layers. A vein will also have those three layers, plus they'll have valves, especially the vessels below the heart, to help move those blood cells back up to the heart to be circulated again. All right, so there is our normal anatomy. Elastic fibers are important in our exam today, the angioplasty. So let's take a look at what we have. All right, so we have the tunica intima, the part cells that touch the lumen or interface with the lumen. Then this squiggly line right here helps maintain the shape of the blood vessel. This is the elastin fibers. So they work on blood regulation, right? So if there is an increase in blood volume coming through, the cell wall will expand. And then when the volume turns back to normal amount of blood through the vessel, the elastin fibers will help return the vessel back to its original size and shape. There are two levels of the elastic fibers. There's the one right next to the intima, and there's another one in between the media and the adventitia. So this is another set of elastin fibers that help maintain that control of blood pressure, right? So if it's too high or too low, these can change the dimensions and make it wider or narrow it and constrict it again. Just depends on what the body needs to do to maintain its blood pressure. All right, definitions, we have two. So concentric is easy. Donuts and bagels, and hopefully our blood vessels have a concentric lumen, or the hole in the center of the donut, right? So that is concentric. Eccentric, we're all pretty familiar with the normal meaning of the term, is unconventional or slightly strange. So you can have an eccentric person, a room can be eclectically decorated, etc. For us in our medical field, we are using the technical version of eccentric. It's of a thing not placed centrally and not having its central axis or other part placed centrally. So here, let me go over to the pen. All right. So here is the lumen of the vessel. All right. So it's obviously not centrally located anymore because we have this eccentric growth of this plaque here. So there was probably an injury of the vessel wall, the normal repair process started, and then sort of went haywire, and cholesterol fibers and more junk gathered here and grew and grew and grew until we have a pretty severely stenosed lumen here. Okay, so that's very good looking. All right, so we'll talk a little bit more about that in just a couple minutes. We'll go in more detail. Indications. So the basic indication is we have a abnormal narrowing of a vascular structure that could be intrinsic or extrinsic in nature. However, it is causing problems with the rest of the body, whether it be backing up things, blood in the body so that it's not working appropriately or some other fallout. All right, so we'll take a look at the subclavian and the brachiocephalic vein. All right, so that would be secondary to a venous catheter. So you have the vessels come in and there's maybe some scarring or some growth here in the center, and you will go in and do an angioplasty and return that to its normal caliber. Okay. Also at the top, we have the thoracic outlet syndrome. Okay. So you have the subclavian vein, because we're talking about the venous and not arterial. So it can happen on venous or arterial, but today we're talking about the venous side. Okay, so that vessel is having it pinched or narrowed for whatever reason, and we'll talk about a little bit more about that in a couple of slides more. Okay, and this happens more to males than to females. All right, so one of the ways to do it is if there's pinching from the bone, you take the bone out. We'll talk more about that later. So SVC constriction. So your superior vena cava is coming back down and into the heart. Okay. So if there's narrowing on it, then you need to go in and open that back up, right? The May-Thurner or Cockett syndrome. Now this one is female more than male. All right, so it is known as the iliac vein compression syndrome. Okay, so just think of pregnancy and the fetus is growing larger. It can impinge on the iliacs as they come back to the IVC, right? So there's going to be some pinching there, and that's going to decrease the luminal size and cause problems. There's other etiology involved, but that's one of the main ones. All right, hemodialysis access catheters. So anybody that has a hemodynamic access port, okay, they can have problems with stenosis in those veins. Okay, so little tongue twister there. Sorry about that. Chiari syndrome is we're going to talk about on the next slide, and the portal vein stenosis. Both of those are concerned with the liver, okay, and the vascular flow exiting the liver. So we'll talk a little bit about that next. All right, so Chiari, it is a liver pathology. So the veins that exit the liver are obstructed and the liver is grown. It is engorged with the blood and other fluids. So we have hepatomegaly as the liver expands. If it is severe enough, it can go over to the spleen and it can be enlarged too, right? So it has grown. So that's splenomegaly. right? So your spleen has grown as well, and that is back up. So problems, problems, problems. Your esophagus, the blood can backflow there, right? And your esophagus will be esophageal varices, all right? And that can be a deadly situation. Some say one of our early presidents, I believe it's George Washington, died of esophageal varice rupture, but at this point, that would be just speculation. So just take it with a grain of salt, right? So ascites, fluid backup. The fluid is not being routed appropriately because there's backup of blood, and then the extracellular fluid builds up as well. So you have an increase of abdominal fluid ascites with this as well, okay? Inferior vena cava is when your vena cava is coming back out, and it's going to the heart. Okay. And if that gets obstructed, you need to go in and fix that, right? Varicose veins. So your abdominal area is getting distended because of all the fluid, and that hurts. So it hurts the skin, etc. So you will have varicose veins on the outside, on the skin, and of course, varicose veins itself can be painful as well. With possible liver damage, you can have cirrhosis. Some of the other things that you might look for here is the person might feel fatigued. They'll have that abdominal pain that we were talking about. They're going to have nausea, and not necessarily vomiting, just nausea. And it can affect the skin color because we are talking about function of the liver and the bile secretion, and you get the backup of and yellow skin. And of course, the white of your eyes will also turn yellow. Bleeding of the esophagus also pertains to these esophageal varices that we talked about earlier. So none of this is good. So we go in and see what we can do to get the portal vein or the other vessels that might be obstructed, get them back to normal caliber, and get rid of all these side effects that were happening. Okay, so Budd Chiari. Fortunately, Budd Chiari is a relatively rare instance, but it does happen. So we need to know what to do about it. All right, so now we're going to talk about intrinsic factors. Unfortunately, atherosclerotic plaque is on the rise. We do have that in our lifestyle. What we do and eat, or lack of activity, all those combinations will increase that. So here we have the core of the plaque, right? So there's cholesterol and some other things in here, and they're dying off. They don't have blood supply because it has a fibrous cap on it. So this is necrotic. Next, we have the fibrous cap that we just mentioned right here. Okay, and that sort of seals everything in underneath it. Problem is, if the fibrous cap is torn off, the cap and the tissue, the dead tissue underneath it, can embolize, and then you have other problems, right? Okay, take a look at the vessel wall over here. Media is very thick. So this is very responsive to blood pressure changes. It can constrict it very well or let it loose, right? Look at the vessel muscle media here. Very, 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 very thin. Okay, so also elastic fibers. For example, you can see this elastic fiber right here, this red section as it goes around the lumen. Here, do you see any of that over here? I see maybe there's something right there, but a lot of the elastic fibers, the elastin, is gone, right? So this is not a responsive vessel to blood pressure anymore, so it can't do that. This also has a bleed right down there. Okay, so intraluminal bleed. And of course, we already talked about the eccentric growth, right? Lots of growth on one side compared to the growth on the other. And that's very, very typical of atherosclerotic plaque. All right. And also, of course, cholesterol in there, et cetera. All right, so that was a cross-sectional. This is a longitudinal version. All right, so we have the media here, it's very nice and thick, away from the plaque. But look what happens here as we look at the plaque area. That is a thin media, right? So this vessel wall has been weakened here because of that erosion of that media. We have that central necrotic core right in here. Okay. Again, you can see that there's lots of necrosis in here, it's just ugly looking, right? Then you have the fibrous cap on top, holding everything in. What happens here is if this comes in and gets damaged, and there starts to be a tear, the blood that's coming on through here will worry at that and open it up and tear off. And then what you have is an embolism that goes down and causes problems later on. Okay, no one wants an embolism, but once this plaque, this fibrous cap breaks off, this dead tissue here can go out, and this flap can open up. So nothing good for us, right? So we want to fix that. Let's see, the intima. So see, the intima here is pretty thick, and it gets pretty larger as it gets closer to the fibrous cap. Okay, so if you notice on the last one, normal intimal layer is very, very thin compared to, and this is a lot thicker. So that changes things in the pathological state. All right. The procedure. Now, for the Loma Linda students that are watching this, they'll have the list of the common factors that I gave you that lists all the details of what we need to do on pretty much every single exam. And this is just a shortened list. So we need to look at labs for coagulation panels. Of course, we need an informed consent. The patient always has to be prepped. And part of that prep is communication. Right? So we're communicating with the patient to prep them for the exam, as well as cleaning their skin. Sterile technique, of course, is required for all of these interventional procedures. And you're going to use goggles, because who wants to get body fluids splashed in their eyes? A cap to prevent hair getting onto the patient. A sterile gown and sterile gloves to make sure that anything that is touching the patient is in a sterile fashion. Okay, vascular access we'll need for all of these cases. It just depends on what vessel you are looking to operate on or perform a angioplasty on. So you might want to go femoral for your portal veins and your IVC, etc. Whereas if you're going for an upper extremity, that might not be the best approach, right? So it just depends on what vessel you're going with, et cetera. And that joins right into what equipment you need, right? So you're going to need a guide wire to guide the catheter to where you want it, right? So depending on where you are in the body and what access point you have, you might need a longer or shorter guide wire, right? So it just depends. You will need one, it's just site specific. Balloon and stent, of course, that's what the whole procedure is about. You're deploying a balloon and you are deploying a stent to open up, make patent a vessel that is stenotic, right? So your balloon is going to be the length is specified by the physician, because they know how long that stenotic area is going to be, and you want to get the right size balloon so that you're not affecting the non-stenotic walls, right? So your stent also is going to be defined by the interventionalist, and so they'll tell you what stent they want and what balloon size. And of course, lastly but not least, local anesthetic, lidocaine, etc., because you don't want your patient to feel what you're doing. Okay. Then you do the therapeutic intervention, which we'll talk about on the next slide. Closing, you also have to make sure the patient's not going to bleed when you pull out everything and send them to the observation unit, right? So you're going to either do manual compression, or you will do a closure device, depending on what vessel you are in and the doctor's preference, right? So there's a variety of things you do, but every procedure will have something to close with, right? So either you're holding manual pressure down for the appropriate amount of time, or you are putting a device in to close that hole that you made in that patient, right? And last but not least, make sure that the patient knows what to do next, right? Aftercare instructions are important. Now, because they just went through a procedure, they might or might not remember what you tell them verbally. So make sure you put that into the chart so that they have a record of what they can and cannot do when they are feeling back like normal, right? So those are the things that we need to do for every procedure. So here we're going to take a look at the thoracic outlet. A couple people defined that, but I think mostly we're going towards the more generic. So you hear thoracic outlet syndrome, and this would be post-resection first rib or the clavicle. So this is an extrinsic factor in the thoracic outlet, right? So the thoracic outlet syndrome can affect the artery, nerves, and the veins. But today we're talking about the veins specifically. All right, so the anatomy involved is you have the clavicle in front that is attached to the manubrium of the sternum, okay? And it courses back and hooks up with the acromion process of the scapula, so that you have the AC joint on one side and the sternoclavicular joint on the other. All right, so beneath that, you have the first rib. The first rib starts posteriorly at T1, courses anteriorly underneath the clavicle, back around, and also joins with the manubrium of the sternum. All right, so you have a gap there. Now we'll take a look. We're going to look at, so here's the rib, first rib coming around, and here's the clavicle. So we're going to look at this section right here where the rib and clavicle are meeting. Okay, so we have the clavicle on top, rib coursing around under the bottom, and normally you'd have this thoracic outlet with enough room for the artery, the plexus of nerves, and the vein to come out. Right, so this is the subclavian artery and subclavian vein. You also have a ligament that connects the first rib to the clavicle. So that's the costoclavicular ligament, and it's right in here. Okay, so what happens if the thoracic outlet is too small? So it can impinge anything within this outlet. So, but today we're talking about the vein in particular. So if it's too small, there is excess growth of that ligament, and it compresses on your vein there. Okay, so all the blood that's coming back through the subclavian vein back to the heart, right? It backs up, so that backs up into the arm, and that causes problems down there. All right, so in order to do that, what they'll do is, if I can find there it is. All right, they'll go in and they'll take a piece of the bone out. They'll do a resection, okay, and whatever part's pinched, is no longer pinched. So intrinsic, if you have an intrinsic vessel, right? Say, for example, you have your brachiocephalic or your superior vena cava coming down, right? There's no really bony structure right next to it. So if you have a plaque buildup in it or excess growth, you go in with your guide wire, deploy your stent, it reopens, and there's no big deal. Problem is with here, at the extrinsic factor, you have this bone that's hard. With this bone that's hard, and if it is pinching, if you balloon it, there's nowhere for that blood vessel to go. It's up against both sides of the bone and a hard ligament as well. So what you have to do is take care of the extrinsic factor. Once that bone is removed, the vessel might open back up to its normal intended size, or you might go in and balloon it. So it just depends on what factors that vessel has once it removes that extrinsic pinching that has been happening. Okay, so there is the both. So the outlet syndrome is extrinsic, happens to males more. The subclavian and brachiocephalic vein or artery, it happens both. Today we're just talking about the veins. Okay, and that would be an intrinsic. So we made it happen by putting in a central catheter, but it is a change to the luminal size on the inside of the lumen, as opposed to something exterior to that vessel pinching it. Okay, so you don't need to do anything beside, you don't have to go in and cut a bone if it's an intrinsic, because all you have to do is go in and balloon and stent it. So these elastic fibers that we've been talking about are important in this part of this procedure. So you have your catheter and you put it in to your lumen. See, I think I'm going to change the color here. All right. So you have your catheter, okay, and on that catheter is sitting the deflated balloon and the stent, and it goes up into where you want it. Now you're going to deploy it. So you take the device to inflate the balloon and you activate it, and that balloon will expand. So let's say the balloon is going to expand like that. All right, so this balloon is going to push this fibrotic cap outward. It's going to compress that plaque as much as that. You see you have these dead spaces here, so it's going to compress all that downward. And if it has to, it will move the vessel wall out too, until the lumen is now nice and thick. So your lumen now, instead of being stenotic, is going to be this wide, because the stent is going to fight against the external forces to recollapse that and have it re-stenose on you. Okay, so you hold that balloon up and inflated for an appropriate amount of time. Your physician will tell you when to deflate the balloon. It needs to be stayed or deployed for a certain amount of time to help whatever elastic fibers that are left remember or reset to a new normal. So they say, we're no longer going to re-stenose or try to go back to the original value, because that will move the plaque back into your lumen, right? So you keep that open. If you're just ballooning, you keep it open for an appropriate amount of time. If you're not, the stent will help fight against the elastin fibers and keep that open, so that you can have a nice blood flow to wherever body part, right, that you're draining. Okay, it's going from that body part back to the heart eventually. Okay. All right, so same thing here. if you have your wire come out, you have your balloon and you open that up, the balloon will push this fibrous cap down. It'll compress this layer of this necrotic tissue, and it can also move the vessel wall out as well. Okay. Now, successful deployment. You have now had a balloon that opened up this full lumen. Now your blood flow is restored and it can empty out all that backlog of the fluid and the blood and easily return back to the heart. So success, there we have it. So then you deflate the balloon and you pull the catheter back out, do a closer device or manual hold, depending on the exam, like I said before, post extractions, and then you're done. All right, so further reading, if you are so inclined, you can look at these sources for more information on those specific disease pathologies. You know, if you want to, not really needed. I did cover them in a little detail. And sources for this lecture came from these books. Specifically, the 4th edition had a good discussion on the Handbook of Radiologic Interventional Procedures, better than the 5th edition, I thought. So I used the 4th edition to talk about this procedure. And remember, you can do a angioplasty just about anywhere, right? And it's going to be very similar in procedure. Very small details of access point and length of the catheter. And of course, the biggest variable will be the balloon size and the stent size. But if you just think of the generalities, then you don't have to memorize as many details for the specific procedure. Oh, well, we can do 30 places. Well, you don't have to remember 30 things. You remember the common factors and the specifics for just that area. Helps quite a bit on how much you have to remember. All right, well, I hope you enjoyed the lecture, and hopefully it was useful for you, and have a wonderful, wonderful day. Thanks.